This week on the BackTable podcast.
If they got them to surgical resection and they looked at many different factors, if they had portal vein thrombosis, if they were above up to 7, if they were all sorts of different things, advanced or non-advanced, the bottom line, the conclusion was the best chance of survival in these advanced HCC patients, similar to what the long-term follow-up of, at least the authors of the long-term follow-up of Dosimetry claim, is that the best chance of survival in these advanced HCCs is to get them to surgical resection.
This is Dosimetry University, Part 3.
All right, welcome back, everybody. Let's continue on. Let's first talk about single session Y90, which your team has just published on. We talked a little bit about it earlier. There's now data from UCSD. There's data from Asia as well.
And Bo Toskich's group.
Yes, I'm sorry. I forgot Mayo. But talk to me about single session Y90. What is the workflow? What does it entail?
As we are getting more and more comfortable with these smaller tumors on the HCC side of things, but it can definitely be extrapolated to metastatic, oligo-metastatic disease as well. The long shunt fraction for these smaller tumors without any aggressive feature, and what we mean by smaller tumors, UNOS T1 and T2, up to 5 centimeter, are very low. And on the other side of kind of the supporting argument for it is that because you're generally doing segmental treatments for these, the prescribed activity is also going to be on the lower side, whether you use glass or resin. The bottom line is that the projected lung dose will be very low. And there, as you said, there are now 4 papers out there showing the Korean paper is mixed glass and resin. There are 2 specific glass paper and also a specific resin paper that we just published about a week ago now, showing great safety profile, no reported radiation pneumonitis in any of them. All of them had 80 to 90% complete response rate. So it's very much there for us to kind of start doing, particularly as other liver-directed therapies are gaining more momentum, including SBRT. I can tell you at our tumor board, it has become a very popular notion that we call it one and done, that you bring the patient in, you treat them in one session and they go home, as opposed to bringing them for a mapping, then bringing them for treatment, or bringing them for fiducial placement and they come back for 3 SBRT sessions. It makes, for certain group of patients, it makes perfect sense. We looked at the economic value of it, and I realized we are in an academic center with a huge backlog, so that makes it more attractive for us to kind of reduce the time. Our average time to treatment for the single session was 21 days, whereas the historical average time to treatment for patients that go through the traditional pathway from the time of discussion in a tumor board and referral to IR clinic was 61 days.
Yeah.
So it's a significant reduction in the time to treatment and 40% reduction in the cost. The mapping component is about $40,000.
Yeah.
Which actually, no, $27,000. The treatment was about $40,000. So it's a significant reduction. So I feel that as more data is published, we may get to a point that insurance companies may demand this, actually.
Okay, I like it. So who do you choose for single session?
So HCCs for now, but it can definitely be oligo-mets as well. Oligo-mets, I'll be honest with you, I've done a fair number of them. They can become challenging in terms of the number of feeders. Yeah, more so than HCC.
Cholangio as well, I feel.
Yeah, cholangio is another.
Cholangio is another.
I think you're right. I like the HCC thing. I think you have to pay attention before advocating it to the masses. I think you have to make sure that your team has a system in place to handle this kind of thing, right? And then there are certain tumor locations that are more favorable for single session deliveries, or at least as you get started. Yeah, as you get started. Yeah. So let's say you're just getting out of there. What kind of tumor location are you looking for, or what would you like if I'm in the community?
That first case that we talked about in the last session, I would not advocate for that as being your first experience, because you have no idea how many feeders those more central tumors.
Because it's a central tumor, right?
Exactly. So more peripheral. I think a segment 6, I think a segment 2 or a segment 3 would be a perfect one as you go.
Not like straddling Q4, but like on the edge of the liver, left lateral.
Right? Yeah. You have to do high quality cone beams. It is essential. That would not even be, it is mandatory. If you're not doing cone beams, if you're not doing the MAA, you really have to rely on your cone beam CT. And we have certain set of, in fact, I had a patient last week or this week, earlier this week on Monday. We were going to do single session. We reverted back to, this is the first case that we have reverted back to mapping. I saw early enhancement of hepatic veins. And I know, and to your point, we did the MAA and the lung shunt came back as 0.9%. Okay.
See, I told you I'm winning.
I know. I was
Winning.
like, man, this guy's good because he was predicted, but
You want to prove it, right?
Not, I mean, if I did it, like the hepatic veins were lighting up. I thought I'm just going to give the MAA and the lung shunt would be 20%.
Yeah.
But it was
It's hard.
not even one.
Very hard.
Yeah.
It was actually quite surprising to me. But so that is the thing. So no macrovascular invasion, no tips. Again, all of these are what the original paper that kind of explained the possibility of this out of Northwestern kind of put it on the map. And intraprocedurally, no early enhancement of the hepatic vein or portal vein.
I agree with you on this. Now you use Sirtex, and so you're ordering not a master vial, but you're ordering a vial,
A mother vial
of activity, and your team, like let's say you catch two feeders, right? Or your team will draw up two separate doses off that vial.
So there are two ways of approaching it. So I learned this, to be fair, from the Korean group. I was visiting them, and I think they were the first group, at least on the resin side of things, doing this. So what they would do is they would do the cone beam, calculate the volume, call nuclear medicine, and ask them to draw the dose, which is fine.
Mm-hmm.
It takes a little bit longer. It takes about 20, 30 minutes for nuke med to draw because there's a mother vial and you draw. So I thought about it. I was like, okay, and we did several cases like that. And then to your point, I thought about, okay, these are all segmental treatments. What are my average volume of segment that I would be treating? I thought, if you look at the 95% confidence interval, it is something in 150 to 250 cc, okay? So I pre-draw 3 vials with 300 gray targeted to 150 cc, 200 cc, and 250 cc. The boxes are ready in the room for me. I don't wait for them to draw or anything like that. We do the cone beam, we calculate the volume, and then go and treat. Yeah. And then if there's more than one feeder, you go to the next one and to the best of your knowledge. And
you pick which one is closest to 150, 200 CV. I like that. And I had assumed that's how you did it, but I wanted you to say it so that everyone else knows that's how you would go about doing it. So we use glass, and we do something very similar. We say that our perfused territories are somewhere between 150 and 200 on average. And we say our institutional lung shunt mean is right around 5 or 6%. And so we assume a lung shunt of what our institutional average is, even though it's negligible for lung dose, really, for a rad-seg. We assume a lung shunt of 6%. We go in 150 to 200 ml to whatever perfused territory. Tumors that are 3 centimeters or less in size tend to rarely have more than 2 feeders. Yeah. So if the tumor's 3 centimeters or less,
for HCCs.
For HCC. Yeah. Now HCC is, because we're talking about, that's where you should really start if you're going to do the single session Y90. Tumors less than 3 centimeters or size tend to have two feeders or less. Yeah. 1 feeder, perfect. You just burn a dose. Yeah. Or you can combine. You can deliver both your doses. Yeah. You can also do that with a split dose, the way I said with Sirtex. You can either double them up, or if you catch 2 feeders and you want to be more selective, you can do that. And so we tend to wind up saying 400 gray to the perfused, or 450 or 500, whatever, to the perfused as an assumption, assuming 200 ml volume. And that activity comes out to, like 1.2 gigabecquerel on a week 1 Friday, or somebody's going to challenge me on the math and actually tell me I was wrong. I'm doing this on the fly in my head. So no one gets to be critical of what I did.
So 2 doses, 200 cc perfused volume each.
Yes. And assuming a lung shunt of 5 to 6% with 400 to 500 gray to the perfused. Okay. Yeah. And so that winds up getting you like a 4 GBQ or 5 GBQ week 1 Friday. Yeah. And it'll be a little bit earlier if you do it.
But you're still cone beam CTing,
brother.
getting that volume,
It is just,
figuring out what the dose is actually going to be.
It is just like you would have done a mapping, right?
Exactly.
It's power injection, and then
You
confirmatory.
make your way
confirmatory to the
angiogram. Yeah.
And then if you just happen to be there ready to deliver, that's what you did.
So let me ask you our honest opinion. I really do think this can become the standard of care.
Agreed.
I think it is good. I think you have to be careful in the appropriate selected patient.
Yes.
The counter argument is, what if I didn't account for a fourth vessel or a third vessel? And I'm just playing devil's advocate here because I've argued this with you.
Come back.
I'm not going to say yes. Well, you were going to come back anyway, right? Because it was a matter.
Let's say it is like 5 to 10% of the tumor.
You could also just
blend them.
you could blend them.
Well, I don't. I think we're going into Y90. So you can. There are some cute techniques to try to alter flow to tumors, which I think you brought up. We might have to talk about at some point. If you were going to do a map and you know how many sessions, or if you were going to do a map and treat, you know how many sessions you're going to? 2. So if you brought them in and you treated part of it and you just realized there's another feeder, you know how many you're going to get? 2.
So actually, there was a case that I did the treatment. It was a single session. I realized after that I totally missed half of it. I brought her back within 2 weeks and I retreated.
Yeah, nothing wrong.
Not retreated.
So
Other portion of
it was basically doing a mapping and a treatment at the same time.
Yeah.
There are financial incentives. You know, a lot of people in private practice, there are RVUs that can be captured by doing a mapping. I don't think that can be I'm not saying that's the right thing to do or the wrong thing to do. I think
that's definitely a factor, though.
But I think there's something that weighs into that.
Yeah.
But I do like single session treatments. You know, we have people that come from out of the country.
Yeah.
We have people that, just like you and everyone else, we have people that come from several hours away, and it's not always feasible for them to come in back and forth. And I would rather them get a good treatment than, you know, be lost to follow up or decide that it was just too hard to get.
And then the other group that was one of our first group of patients that we did were the patients that were incarcerated. The prison. Okay, because there's a lot of logistics. I don't know if you treat any of those people. There's a lot of logistics involved. It takes months to bring them, even if you approve a procedure and you want to do something. So bringing them once makes it so much easier than bringing them.
It's a great point. 2 things I want to comment on. One, this whole 5% thing. Let's say you have a little bit of an edge of a tumor, what to do with that. I totally agree. For me, it is what is the perfused volume that is around that edge of the tumor, right? If I have to get that 5% of tumor, I have to take 200 cc's of normal liver with it, then I'm probably not going to do that. I'm either going to balloon occlude the outflow and then give a proximal dose with a sniper or something like that, or I'll do blend. I know you don't like blend, but it's number 1 is killing tumor. Number 1A for me is sparing normal liver, right?
So Riyadh, we learned the technique from Riyadh, and I'm not advocating this for someone to just try this on the fly. Like I think you need to understand what you're dealing with. But you can get, as opposed to doing a particle embolization, you can get right up on the tumor and you coil it prior to treating it. It alters the vascular inflow of the tumor. So if you coil as close as you can to the tumor, I'm talking like right up on it.
Sure.
If you can get right up on it and coil it, or get close to it and coil it, all of a sudden the inflow associated with the tumor can get redirected. And so
this
is for the tiny segment.
For that tiny little 5% feeder. If you can coil it, it'll change the flow dynamics of the tumor, and you can wind up treating. Riyadh has talked about this several times. Juan has had great experience with this. I don't love it just because I feel like it's a factor that you can't always guarantee that you're going to get the best response. So also, if there's a 5% residual or 5% area that you can't go, you can always change your modality of treatment. You can ablate, you can put a little
100%.
The other thing to consider that I always think about it, at least, is radiation travels as well. So we have a range, like if you have 5% in the rim of the tumor, but you have a hot dose of radiation right next to it, there is a 0.5 centimeter to centimeter that this radiation travels. So,
but it's only 10% of the time, 10% of every decay. And so I try not to rely on
I know.
I think it's a fair consideration, but I would like to rely on factors that I feel like can give me the most lethal kill possible. And I feel more confident doing either an ablation or Y90. I just don't like bland embo for the intent that you're going in there to try to use it for.
So there's bland embo for reperfusion and there's bland embo for treatment.
Yeah.
In a case like this, I would use a smaller particles. I would use 1 to 300 embospheres for the treatment. If I was doing reperfusion, I would use larger particles because I would want the Y90 to go. This is not a case that we're talking about, but But anyways, I actually think it will have a bigger role in the future, notwithstanding the financial implications in private practices, but at least in academic centers where there is generally a backlog of patients and a large group of patients, a subset can definitely be treated.
Oh, I love it. I think it's a great opportunity. Single session Y90 is a great opportunity for patients.
And streamlining the process for the patient, right?
Yeah.
I mean, that's what this is about, and getting them treated faster. I will say, though, from a flow redirection standpoint, I'm sure we're aligned on this, but I don't agree with coiling the left hepatic to then just treat the right hepatic for a large lesion.
No.
That-
I mean, never like 5%
Agreed.
of a very small,
Agreed.
like a subsegmental vessel
Agreed.
that you just didn't want to treat 200 mLs of that territory. And the predator technique is good, right? You talked about using a balloon occlusion. You know, Bo Toshkich, and this is, you got to do this very, very well, but it's called predating a vessel. So it's actually like, you know, pruning off the vessel. And if he listens to this podcast, he's going to destroy me. But the gel foam has to be mixed perfectly. And the way that he talks about it is you get all the air out. It's a very, very thin solution, and you can actually see the gel foam particles sit in suspension in the syringe if you were to hold it up to the light. So it's not a thick gel foam, and it winds up, and it's all intended to go do a very distal embolization. And Sirtex is coming out with a rapidly dissolving particle.
They have it in Europe already called EmboSep.
Yeah.
And so it should
But
be
it's
coming
small. It's
soon.
50 micron, right?
50 micron.
50
Yeah.
micron.
But the company at least has the capability of making larger particles with different resorption rate. So what is your go-to technique for reperfusion?
So reperfusion.
Yeah. So if you want to protect a certain,
So I will do
or not
Redirection.
redirection.
very rarely will I use gel foam to kind of prune out the distal. I would tell you I've tried to use the balloon thing. The balloon thing I've had, people don't understand how hard it is to put two catheters through a sheath, through a single sheath. And so like our 6 French sheath, if I situate it in the common hepatic artery and I try to put a sniper or a scepter through it and then try to put even a true select through it.
Not the easiest.
It's not the easiest thing in the world. And things just get sticky.
You have to go through the hub of the sheath and all.
Yeah, there's a lot of complexity associated with that tends. Give me a second. I know what you're gonna say.
Because I do it all the time, and I love
know
it. So,
you do, and I think it sucks. I'm not saying we can disagree on a few things. I tried to do it a couple times, and I was like, Kavi's full of shit. I was like, he tells me he does it and it works fine. I was like, no, it doesn't. I was like, I'm sitting here, I'm getting frustrated. Now, Kavi will say you can access both vessels and you can do it 2 different catheters.
You can. I don't do it.
I know you have techniques that make all this work. I have not had many good, and I might not be as good as you guys at Y90. For redirection, I like distal gel foam. I use it very rarely. At the end of the day, I am pretty good with the microcatheter, and I love the shape steerable the direction microcatheter. Everybody hates it. I
actually love.
I'm going to be the only one that keeps them in business.
Which one?
Either the urn.
I love it. I love it.
So
That's the only shape microcatheter that actually torques.
Yes,
The rest of them,
they don't.
Even True Select, which is made by Boston, the shaped one.
But if you,
I don't like it.
If you don't treat that direction nicely, it will
go out.
So you can break it because of the way so you got to be very delicate with it. But it is very steerable, very shapeable. I find that I can catheterize most of the branches the way that I want to. So I rarely run into an issue where I need to alter flow. But that said, I like gel foam. I use it rarely. The coil thing, very incredible. I might have done it once. And that balloon thing, I tried it several times because Kavi swore by it, and
I've done
it. It does it.
I know it. We've done radial.
Yeah.
So I put a R2P sheet. It's a little bit easier than the groin. I don't like gel foam. I had some.
You got to be delicate. Yeah,
I know. I'm not.
Then you got to mix it very meticulously.
Yes, and that was what I tried.
Larger particles. I get more consistent. I do 300 to 500 spheres.
There are calibrated gel foam particles in Asia. Hopefully, they will come to the U.S. at some point. That would be ideal.
But EmboSept is going to be. I
EmboSept.
can't wait to try it.
EmboSept is going to be
because it dissolves in 30 minutes. Right?
Yeah.
Like it. I think it's going to be awesome.
That's actually a perfect product
application for it.
And
so, Kavi, how do you do this?
The double
balloon. Yeah,
so,
balloon bullshit that we'll talk about.
So 6 French sheath or double access or 6 French sheath. The goal is 6 French sheath, right? Interestingly, the R2Ps, I find them a little stiff, so I don't like doing this from radial personally, but it definitely can be done.
I've only done it through radial.
Definitely can be done. But 6 French sheath, you got to take the check flow off, and then it is a double TUI neuro technique. that's the way that it works, right? So two TUIs connected to each other, two microcatheters go in side by side, and I like it. Now, I will say on the topic of gel foam, and Bo talks about this a lot, especially with HCC, you will get intrahepatic peribiliary collaterals that can collateralize around the balloon. I've also seen it many times. So you can then, with the balloon up, inject your gel foam safely because it's not going to reflux, right?
Yeah.
So Bo talks about that a lot as well. I think that's a great little technique, but I am a little partial to the
So
again, sparing normal liver,
mentioned
right?
balloon.
Yeah.
I have to say,
Yeah.
what about other flow diverting or flow modifying microcatheters? It is a great question. This is controversial. I have to say, we have to kind of bring it because I get asked all the time, and I don't actually.
I get asked this a lot, or
Yeah.
I get told that people say that I use this often, and we actually don't. And so our practice, again, is built around a lot of rad segs. Like I would say 90%, even in the metastatic game, we try to rad seg, and we talked about this because it allows you to spare normal tissue.
Yeah.
I think there is a role for flow, or for, I guess we're going to talk about the TriNav catheter, the one
and,
you allude, or Sniper.
Yeah.
I think that TriNav is a very good anti-reflux catheter, and it allows you to protect proximally what you're trying to, assuming the valve gets situated, opposes the vessel from which it's treating. I have not had 100% reproducible experience of altering the T to N ratio using either a Sniper or a TriNav. And so
Meaning comparing MAA to...
Or seeing altered, like even when I have the TriNav in, let's say I'm dealing with a diffuse hypovascular set of tumors, or multifocal hypervascular tumors, I don't see the vascular changes that I would want to see with the TriNav catheter to trust it all the time.
Angiographically.
Angiographically. Because there's no way to really do it with MAA and then say it on the back end.
Yeah.
To have confidence that it's going to behave the way I'd want it to do favorable flow to tumor. That said, if there's no other option, if I have a patient with, and we'll probably talk about this in a little while, with bilobar hypovascular metastatic disease, or even unilobar multifocal hypovascular metastatic disease, I will pull that catheter out in the hopes that it alters the perfusion and use it in that setting. But the majority of our practice is rad seg. I would rather get the catheter closer to the tumor and doing a more distal rad seg to a smaller territory where I have more confidence that the dose gets delivered into the tumor the way I want to. So I tend to not use them.
I actually resisted. So you had Sniper at Emory, and I used it quite a few times.
Not for distal protection. You're injecting with the balloon up.
Yeah.
Right? So, yeah.
I've been approached to use a TriNav, and until very recently, I didn't use it because to me, that basket size that they had was too small for anything lobar. And to your point, I think the biggest potential benefit of any of these potential flow modifying catheters are for in a lobar setting, not in a segmental setting. I have started using it since they came up with the larger basket size that goes up to 5 millimeter, because then you can actually do it in a lobar setting.
Yeah.
I haven't looked at the data apples to see truly whether it has increased the T2N or not. But in terms of the trackability and in terms of the ease of use, I've been quite impressed with it. But definitely it requires more data to claim what it could do.
That's what it is.
Could not.
I think we're lacking clinical data, right?
Yeah.
That's the problem. And
It's a hard one to do, though. To generate the data is not
that's the problem.
Yeah.
That is exactly.
Because how do you prove? Because every patient is different. Every catheter position is different. There's a lot. There's a lot of nuances to it. That's not to say it's not a good tool. And I think it has its role. And I think you just got to understand where you're going to apply it in your practice.
Yeah.
I don't think it should be applied in a rad seg application. I think it's more in a large volume, low bar type approach.
When you have a lot of background liver in the territory, right? And so low bar, I'll use TriNav. If I'm more selective and I still have a lot of background liver that I can't protect, then I'll treat with the balloon up.
Yeah.
But you're right. I mean, I think the clinical data is lacking, and that's
and
especially when the catheters are expensive.
For any of them, I don't consider them an anti-reflux.
Yeah.
I don't care about that as much. I truly care about if what they claim is if you put the balloon up or the basket is opposing the wall, there will be vasoconstriction in the normal liver parenchyma more than the tumor. And that is the hypothesis.
That's the hypothesis.
But we need to generate that data to prove that,
Exactly. I agree with you 100%.
And worth noting, on an economic standpoint, both catheters are expensive, but hopefully reimbursed on the back end with proper coding, correct?
Yeah.
But those aren't RVUs that go to you. That's very, people need to understand. You're not getting more RVUs because you use catheter, but you're getting C codes which get reimbursed to
Your hospital administrators like you.
Yes.
So you should not be losing money on the catheter. That's what I'm trying to
Correct.
If you're in a private practice, your partners.
These catheters allow you to be more embolic.
Yeah.
Like, so you can put more particles. Like, we use TriNav for our chemoembolizations for the most part. When we treat, multifocal neuroendocrines, you can be more embolic, but I don't know that that's necessarily the game with Y90.
Well, there's also some concern that you can push, if you're really getting to stasis, you can push particles through shunts.
Actually, a colleague of mine had, and that's why since I've started using it, I do mapping and treatment with it, because I'm concerned that things would change significantly during the mapping if you got an end-hold versus a TriNav for the treatment. A colleague had a radiation pneumonitis from a radiation segmentectomy using TriNav.
Yep.
With a very negligible lung shunt fraction on the end-hole catheter with MAA.
I think it's a great point. You got to replicate what you're doing, and I'm guilty of this. I don't always think about it at the time of the mapping, but replicating mapping to delivery.
The other issue was the financial aspect. Up until April 1st of a month ago now, they didn't have a code that would get reimbursed for mapping. Yeah. Now they do. Just so
for TriNav and Sniper, or just TriNav?
I think the code would apply to both.
To both. Okay. I'm actually not sure. So
I don't know. I mean, I suspect.
I suspect so as well. But okay. All right. Time for a case?
Sure, let's do it.
Let's do a case. All right. So large tumor case from Tyler Sandow.
Yes. So Nima shows easy cases. I just want you to know that I'm going to show hard cases. I brought this case only because I think there's some important things to consider during the mapping. And we had some great discussion on that rad seg, and I don't know that we necessarily need to dive too heavy on this, but the mapping is going to play a critical role in this case, and there's some things to consider because they become relevant on the back end. 49-year-old patient with Hep B cirrhosis, massive tumor, right? It's a fun one because you see how it's well encapsulated. You can imagine that you're probably going to get a good response because that encapsulation tends to suggest that it's more of a well-diff, moderate diff biology as opposed to the infiltrative component.
I worry about those. When I see this size and infiltrative.
Yeah, you're probably on the back end. But this is AFP's low, large tumor. I bring this up only to highlight some of the important parts of the mapping. So we always do power injections proximally, and then we try to catheterize from the area that we treat. Now, I was a big proponent. The first time I gave one of my talks, I was presenting in front of Riyadh, and I talked about how when we treat large tumors, we try to do multi-vessel rad segs. We treat each individual vessel as a rad seg. And Riyadh told me at one point, he was like, you may get tired of doing that, and you may just give a proximal, like 20 GBQ dose or a proximal dose, recognizing that you're going to come back regardless of what you're doing. And this gives you the opportunity to clean it up. Now, I did this maybe 4 years ago. This case was 4 or 5 years old. I learned my lesson here because I almost got burned. But there's two big components feeding this tumor. There's a segment 4 branch, which you can see, and there's also a right hepatic artery that's basically perfusing the entirety of the tumor. I thought, hey, this is covering the majority of the tumor on that right hepatic artery branch. I didn't recognize how much that volume of perfused territory was going to impact my dose decision down the road. And Nima, we would talk about this just a second ago. So I did the mapping, and this was basically as far as I took my catheters. I didn't actually go any further. I did that segment 4 branch. I'm going to do a rad seg right there, and I'm going to do a low bar dose from the right hepatic artery right here. And I was thinking, hey, Dosimetry showed 200 gray target to the perfused territory. I'm just going to try to shoot for 200 gray target to the perfused territory, all right? And so here we are, and Nima's laughing because he knows exactly what's about to happen. And so the good thing, what worked in my favor, and only because of this, it worked in my favor, the lung shunt is 3. And so because the next thing is, if your perfused volume is 1,500 and you're trying to get 200 gray to 1,500 mLs worth of tissue, your lung dose, if it's 5%, you're really teetering on 30 gray to the total to the lung.
We haven't really hit on this yet, optimal particle count in these types of tumors. How does that 200 gray and particle count, how does particle count weigh into determination for what vial to choose or what dose to give?
I don't necessarily know that 200 gray is the right target, right? So Dosimetry targeted 200 gray to the perfused, or to the tumor. That was where that concept of personalized dosimetry with partition dosimetry that we talked about earlier came into play. Dosimetry targeted 200 gray to the tumor. the tumor doses were actually closer to 330 gray. So that's very important.
They say 2.5 gray or higher.
But the dosing was, the tumors actually got closer to 330 gray.
Yeah.
But they were dealing with tumors 10 centimeters or greater, similar to this. And the ones that were targeted 120 with standard dosimetry actually got tumoral doses closer to 200, right? So again, the concept of higher doses to tumor implies a better kill because again, more hits, more lethality.
But this is 200 gray to perfused volume, so you do expect your tumoral dose to be higher.
If your tumor is occupying your entire perfused volume,
exactly,
you can't really improve on 200 gray. And so that's an important piece to consider. I go in here with the thought of, I know I'm coming back. Right, there's going to be cleanup work that needs to be done for a big tumor like this. I don't think, regardless of whether you used a high particle count with low sphere activity, I don't think you're ever going to be done.
Yeah, I always prepare them for at least 2 sessions.
Yeah, for a big tumor like this, you're going to be playing. And so
now this is 4 years ago, and you use a week 1 Wednesday. Because if I was using glass for here, I would go as late second week as possible. Would you consider that now, or would you still use the same?
I recognize for a tumor like this, I recognize that there's going to be heterogeneous sphere deposition in the tumor.
Yeah.
And there's going to be areas that are going to die right away, and then the areas that are going to be viable. I still like, because I would rather each particle be Chuck Norris-like, Bo says, I would rather throw a bunch of Chuck Norrises and then throw a bunch of more Chuck Norrises. I don't know that I would do week 1 Wednesday, but I might do week 2 Monday. Or I might do
getting there.
Week 2. He's loaded, but
you need the Chuck Norris head down, right? So
I in a large tumor,
because this is huge.
It's huge, right? The perfused tumor is like 2,000. It's 2,000 mLs. But again, I don't necessarily like 190 gray, but I got stuck, right? So 4 years ago, this is what I would have done. Today, I would have actually catheterized each individual branch, and that's where the mapping plays a critical role. Had I catheterized all of those feeding valves, my perfused volumes might have been 500 and 400 and 600. And then we would be talking about doses of 200. We'd be talking about individual doses in a staged fashion, multiple sessions at maybe 400 or 5. So I would have been a little bit more lethal. I don't know that I was still done week 1 Wednesday. I might have done week 1 Friday or week 2 Monday. That's where I would have probably stayed. But an important point is if you're not paying attention to this and you do a mapping proximally without going out and feeding or getting into these branches, that lung shunt was 3. If the lung shunt is 6, the lung dose is going to be 30 gray. So,
even with a very minimal lung shunt fraction.
Yes.
That's why lung shunt fraction should not be used. Projected dose of lung shunt.
Yes.
Agreed. 2 comments. One, based on the available, true or false for both of you, based on the available literature we have, you cannot completely overcome heterogeneous sphere density by just increasing particles.
I agree with you.
So both true. You both agree? Yeah, agreed.
In a case like this,
Yeah.
I don't particularly pay attention to the number of microspheres. Because I only care about number of microspheres, at least at this point, for cases that I want to get complete response.
Sure. No,
because
agreed.
we say, okay, this is the goal here is curative. That is the bar. Anything below that is suboptimal. So let's maximize our chances of improve. Because I think paying attention to the number of microspheres here could lead you down very dangerous paths.
Especially when you're just starting out, just get the dose in there, right? Like there's going to be cleanup.
Well, I'm just making the point that you're never going to get homogeneous deposition of particles. You can go to 200 million particles.
Exactly.
You're still not going to get homogeneous.
So if I was doing this with resin, I would say that's why I asked Tyler what he would do now. And I think he would use at least a calibration that has higher number of particles, not to the extent that, we want 40,000 or 30,000 microspheres per second. There's no way you can get that.
I would still, if I were using resin, I would still want to use a Precal 7. But just because
I wouldn't.
So, well, that's fine. Yeah. And, but I still like the individual sphere activity component.
Yeah.
And so.
Yeah. So that I would use a 2-day Precal or a 1-day Precal here, because I kind of, again, a lot of this was more of an art of it as opposed to the science of it.
Great.
And hopefully
we don't know the right answer.
I don't know what the
I still like high activity spheres.
Of course.
And so I think we're all going to say at some point getting the activity in those voxels is going to be what's going to drive your best component. So so he did great, but we do 1 month follow-ups for everybody. Now this is another
I do the same
touch point, right?
Yeah.
So we have a patient that has a 1 month follow-up and the tumor looks like it was hardly touched. Now we put 200 gray in there, not 500 gray. you don't necessarily see big responses with subablative dosing at 1 month.
That's a very good point.
But it's also not something you want to see here, where it's like, well, the tumor looks like it might have gotten a little slightly bigger.
Or can I play devil's advocate and say that you had very hot islands of hot doses?
100%.
And that's why I asked you. I think eventually we will get to a point that say, regardless of what device you use, this is for a certain size tumor. This is the optimal intersect between specific activity and how much particles you need to achieve a certain result,
I still think if we're going to go to let's play it at the 1 ml level or at the 1% level, I still think that whatever drives your activity, whether it be hot spheres or mini spheres, like I know that there is going to be voids here, but on the same token, there may be activity voids with mini cold spheres, right?
But
or less than hot
That
spheres.
is true. That the issue with large perfused volume like this is you're limited by your projected lung dose.
Exactly. It's always about the lung.
Yeah.
And
so then you have to just kind of titrate based on that.
So my goal here would be to do whatever the lung dose would allow me to do. And from a convenience standpoint, I didn't want to put, like, if I would have had to do 400 gray to this perfused territory, I would have had to do several connected boxes, and I hate connecting my boxes. So an 18 GBQ vial week 1 Wednesday just kind of fit within what I felt like the parameters were, and I know we're cleaning this up.
Yeah.
So then we cleaned it up, right? So we should have. Now, at 1 month, I guess reasonably, you could say, hey, there's no progression. Should we wait?
There's disease control.
Yes, disease control.
There's control.
SBRT data right there for you.
Yeah, exactly.
I will make the point, we're not disparaging any other local regional therapies. We're optimizing Y90.
Tyler is. I'm not.
It's fine.
None of us.
Friends who have friends that are rad-ons. We're good. No, I love our guys, and I work with some of the most special rad-ons. I just like to joke. Everybody knows me. I think you could wait. I think you could wait and say, maybe I'm not seeing the
Maybe too early of a follow-up.
Yeah. I don't like doing that. So we brought them back, and we remapped.
I would totally agree with you.
So we brought them back. We did more of a selective mapping where we sought out the individual feeders, but this time the lung shunt went up on us.
That's interesting in itself.
Whether it actually went up or was it just how truly what it was?
Yeah.
You just didn't capture it.
Well, that's good. Even if it was 6, the first time the lung dose would have been 30 gray, but we were okay. But this time we're going to pretend like it's 6. So my intention now is to do multiple rad-seg, and that's how I like to treat large tumors. I like to do multi-catheter, uni-compartment rad-seg.
That's also what I like to do. So I want to point out this is 2 months after initial therapy.
So this is probably, I mean, in terms of scheduling this is probably like 3
months. Okay, fine.
Down.
So if you had any lung issues from the first therapy,
you would have seen it.
You would have seen it.
At this point now, yes, you would have seen it. So in reality, this is probably about 4 months from the time the patient got treated.
Okay.
And so you can always shade or window how this thing looks. This is what the rad-seg looks like. We put 268 gray. This is week 2 Monday now, so we're using 570 becquerel per sphere type activity. And so we're at 260 gray, 268 gray, and then 400 gray off that segment 5. So now the lung dose, again, is 18 for this session. Cumulative lung dose is 33. Still heterogeneous distribution. Some of those voids, but this is 1 month follow-up again. Again, we're still at this point. What do? Bring them back, remapped, did another.
Lung shunt keeps going up.
I know. Have you noticed? Yeah, I know. I don't know what to tell you, but I'm reporting it the way it is. And we do another one. So now we have done a fractionated type approach to this where we've hit 200 gray, 200 gray, 200 gray, but we've played on the heterogeneity associated with the areas of viability. And you can see there are areas that are viable now that weren't as viable before. And then we get another follow-up. And this is what it looks like, again, at 1 month. And so you can see it's dying. Now, what I know now, I'd probably sit on this for another 3-6 months.
Oh, really?
That is probably dying tumor. You see that spider-like look to it?
From the subablative dosing, repeated subablative dosing.
Right, because at this point, we'd probably accumulate it, like 200 plus 200 to the same territory is probably closer to 400.
Yeah.
And so that wispy spider-like approach, our spider-like appearance of the tumor now is dying tissue.
And your hypertrophy in the left lobe as well.
I know, right?
Which is great.
Yeah, totally. And so it's really
it's not growing. That's the thing.
The tumor's not growing.
Yeah, the tumor's not growing. Yeah.
So still didn't like the way it looks at that point in time. This is again 3 years ago or 4 years ago. So I wanted to clean it up and make it look pretty. So I So you can particle the hell out of something and then make it not enhance anymore. And that's what I did. And so
I mean to taste.
I know. Well, it's, I think it has its
He's
role.
mean to the tumor, appropriately so, right? So,
But here we go. And this looks great.
Yeah.
You can see that little wisp of tissue that
That's nothing. Yeah.
well, you would hope. When I originally thought it was nothing, but this is what it looks like 6 months post-test.
well, that's something.
And so all of a sudden you're like, all right, well. And so we actually brought this guy back for Y90 again, and we had 2 different feeders to it, and that was where we are. And we had a incredibly lethal dose to the tumor. So now we're at 500 gray because again we're looking at perfused volumes of 30 and 40, 30 and 24.
Oh,
Yeah.
higher.
And your
What was
activity.
your long shot fraction here?
Oh gosh.
12%.
Yeah. Okay. It was no. I want to say it was probably close to 8 or 9, but
So here's what, let's say you were already at 50, 51, 50, we should say 50 gray from the previous treatments.
I think I would still try to.
Would you? Okay.
so we've done it. So this is a guy that's been treated over the course of a year to 2 years worth of Y90 and has had good responses, had tolerated the lung dose as well. He's a male. He's taller. So his lung volumes are probably larger. So the lung doses are probably overestimated in him. So he could probably tolerate a little bit more.
And you're using smaller particle counts, right? So
But if he were a petite female, I might consider that I've probably touched my limit. But he's a larger male.
Okay.
Right?
I would taste it.
you would taste it. Okay.
Yeah. And I like C taste. I don't.
You can also ablate this. I think it's reasonable to do a perc ablation.
Yeah.
Having ablated Y90 cavities before, it feels very, very funky when you're putting the needle in. It feels like you're pushing through a rubber tire because it's
Scar
so
tissue,
thin.
fibrotic
Yeah.
tissue, right? Yeah.
You gotta be careful with that. But yeah, I think all those approaches are reasonable.
SBRT here? Maybe SBRT?
I don't think any radonc would agree to SPRT just given how much radiation is already given. Maybe it's not my area of expertise, but
I don't know either. I think Michigan just published a pilot trial on combination Y90 plus SBRT. I think if you're focal and localized and there's not a lot of normal tissue dose from the Y90, like you didn't give a lot of lobar dose, right? These were all selected, except for the first treatment. Maybe that's a reasonable thought. We're not radiation oncologists. I don't know, but it's an interesting thought.
an option if they
agree.
feel that it's safe.
On combo Y90 and SBRT. So anyway, just an aside. So.
When you calculate the volume of liver treated too, I think this is an important point. When you're dealing with large tumors and you talk about, percent total liver treated, you need to exclude the volume of tumor, right? And so actually we're not treating a lot of normal liver in any of these.
So let me ask you this. This is an important kind of thing that I've recently recognized, and we don't do this as much here in the United States. Well, I thought, is this patient still surviving?
Oh, brother, he's alive and thriving. Loves me.
That's great.
Loves me.
That's great. So a very kind of eye-opening data that was published was the long-term follow-up of Dosimetry trial. That they showed significant sustained benefit of survival for those patients that were all large tumors, but only if they got to surgical resection. Actually, there was no difference in survival for the personalized dosimetry versus no personalized dosimetry if they did not undergo surgical resection.
You ready for me to hit this one?
I would love to, because this is the perfect patient of that sort, right?
Yes. And so they tried to do surgical resection. They went in and kind of balked at it when they opened him. They thought that there was more tumor burden than they previously assumed. And so we wound up having him back to us to do Y90 to that little focal area. That was what they thought.
Also, initially they took him to...
They were going to.
Yeah.
They balked at it.
So what do you think about that? Because that's not something we do in the U.S.
I think it's important to understand dosisphere. People don't know this, but dosisphere, because it was a randomized control trial, all of the patients received one treatment. The majority of the responses in dosisphere were partial responses. Now, they had great response rates.
As you would expect with large tumors.
Yes, you will get a
treatment, right? So
agreed. Partial response. So take dosisphere within the context of the way it was done. You did one treatment. You were allowed one Y90 treatment. You were not allowed two. So a lot of them are partial responses. In our world, I treat that patient and I know that they get a partial response, whether or not it's a partial response at a year or whatever. You're coming back to clean that up, right? That's what you would do. That's what I would do. That's what anyone would do. They weren't allowed to do that in Dosisphere. So if you have to sit there and watch a tumor progress short of getting it resected, obviously the ones that got a better long-term treatment with resection are going to do better than the ones that got Y90 only. So Dosisphere, the limitation of understanding the data talking about resection or the long-term survivability in resection in Dosisphere has to be taken in the context of those patients were only allowed one treatment. We don't know what would have happened if you would have gotten the opportunity to go back and clean it up over and over and over again.
So I thought about that exactly. And I all of us have been involved in clinical trials. We know the limitations. But then a similar data came out of Singapore on the resin side. 413 patients treated with resin with HCC. 70 of them were downstage. These were all large tumorish. They were not as advanced. All of them were not as advanced as the Dosisphere study. If they got to surgical resection, median overall survival of 72 months.
Yeah.
Which is similar to what Dosisphere showed on the 6-year follow-up or 5-year follow-up. Again, downstaging them to surgical resection. That was not part of a trial, so I have to go back and look and see if they were retreated
Multiple times or not.
multiple times. But the bottom line was, if they got them to surgical resection, and they looked at many different factors, if they had portal vein thrombosis, if they were above up to 7, if they were all sorts of different things, advanced or non-advanced, the bottom line, the conclusion was the best chance of survival in these advanced HCC patients, similar to what the long-term follow-up of, at least the authors of the long-term follow-up of Dosisphere claim, is that the best chance of survival in these advanced HCCs is to get them to surgical resection. We don't practice that in the U.S., and it's been a bit of an eye-opening.
I think it allows you great collaboration with surgical oncologists, right? But again, I think Y90 can kill, right? And if you use Y90 the right way,
You're talking about a blade dosing. Yeah.
You just wind up.
But not everybody is as persistent as you are. You have to realize that, right?
Yeah, but you would have done this.
I know, but I mean, that's not something that happens in the real world.
But I think that's the evolution in the space.
Yeah.
Right? Like, we are not just giving a low bar dose and running away.
Yeah.
We are hammering these, especially larger tumors, with repeated doses, repeated treatments. And then you brought up the concept of multimodal therapy, right? I mean, like, we get stuck in this box where Y90, we're just going to Y90 everything. And it can only be Y90. And in reality, you can mix and match therapies in these patients for better efficacy, right? We know that. I mean, the Loyola paper that came out, right? I mean, like, you get good outcomes.
Yeah.
So I do think this is the way of the future. Yes, maybe there's a little bit of a disparity in practice around, across the country and in the world, but to me, this is the direction we're going.
But I wouldn't stop anybody if they wanted to go resect it.
Yeah, I think my also to bring this up was, I mean, I obviously believe in Y90, but should we push more, or should we bring these data to the attention of our surgical oncologists and look?
Oh, see,
this is something that we haven't done before here much, because when we talk about, this is not a surgical candidate.
So it came from a surgical oncologist.
Yeah.
And we were treating him over time. And I was like, hey, man, looks like this is some viable tumor. Do you want to resect now? We're kind of at the top end of what our lung dose would be anyway. You want to go resect it? And
but this was after multiple treatments,
after
right?
multiple Y90s. Yeah. And so he tried, and there are issues associated with trying to resect the liver. And I work with some incredible surgical oncologists.
Yeah.
They're doing an explant, a whole liver explant, as opposed to a partial liver resection. There are intricacies of doing that, of course, after getting a Y90. And so there's a lot of adhesions. There's scarring. There's valve that anchors to it. So it's not like it's an easy resection for them anyway. But I think, so if they can get resected, I'm on board.
Because you had adequate future liver or FLR, sure, by doing all of that.
But you're not saying stop trying to treat and go to resection. You're saying treat until you can't treat.
But or treat.
Even despite, it seems like, at least based on both, again, Dosisphere was more partial response, but even the Singaporean data, it seems like despite what you get, if you want to follow these patients for 5-6+ years, their best chance of survival is to get that, whether the tumor is viable or not, get it out of there.
Yeah, I can't disagree with that statement. I think if you can't resect it, then you look at doing something else. But I think that's 100% accurate.
And this goes back to what we talked about earlier. I mean, you effectively gave that patient a test of time. They didn't recur on the left side.
No.
So then, you go to surgery. I mean, that makes complete sense.
Thank you guys so much for tuning in.
If you haven't already, please be sure to subscribe, follow, and rate the show. Let us know how we're doing and what we can do to improve it. We work really hard at making this a valuable resource for you, and we want to continue to do that. So give us your feedback. Lastly, tell a colleague about the show. We think they'll like it. If you have any questions or comments, direct message us at _BackTable on Instagram, LinkedIn, X, TikTok, and Blue Sky. BackTable is hosted and produced by myself, Chris Beck, and co-hosts
Ali Behetti,
Michael Barraza,
Sabine Dond,
and Aaron Fritz.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang, Manisha Naganathanahali,
and Manbir Singh Sandow.
Administrative support provided by Judy Dela Cruz.
Thanks again and see you next time.